In a Tier 2 Indian city such as Solapur, public health does not begin inside a hospital. It begins in the lane outside a home, in water storage, drainage flow, waste removal, and the density of everyday life. The city functions. Services operate. Field teams move daily. But pressure builds, not as collapse, but as accumulation. Inside the municipal office, information exists in registers, spreadsheets, and printed summaries. Rainfall advisories arrive from the India Meteorological Department. Surveillance updates are compiled under the Integrated Disease Surveillance Program. Each department performs its duty. Yet each system operates independently. Rainfall data sits in one place. Garbage backlog in another. Complaints elsewhere. To understand risk, officers must manually connect them. But public health risk emerges through correlation. The municipal intelligence layer does not replace existing systems, it connects them. Complaint feeds, sanitation logs, rainfall data, seasonal markers, and ward-level health aggregates are brought together into a single analytical view. No single signal triggers escalation. Only when multiple indicators align within a defined time frame does risk become visible. Each ward receives a risk level, confidence score, and data freshness indicator. Time is factored in. Rain today does not mean illness today. Incubation delays are accounted for, reducing false alarms. Context refines interpretation. High-density settlements, shared water access, and constrained drainage increase exposure. Vulnerability multipliers adjust thresholds. Occupational clusters and respiratory baselines are considered. Maternal, child, and elderly vulnerability indicators guide proactive intervention, without accessing patient records or diagnosis data. Additional proxy signals, such as aggregate ORS dispatch trends or school attendance anomalies, strengthen confidence when patterns converge. Resources remain finite. Fogging vehicles, drainage crews, and field teams are limited. The system ranks wards by projected impact, enabling rational prioritization. Analysis leads to action. Drains are cleared. Water is chlorinated. Waste is removed. Geotag verification closes each alert. Governance becomes traceable. When data is incomplete, uncertainty is displayed. Absence of data is not treated as absence of risk. Seasonal stress, monsoon, pilgrimages, population surges, is anticipated in advance. Preparedness is scheduled before strain accumulates. The system operates strictly at ward-level aggregation. It strengthens coordination within municipal authority, without entering clinical jurisdiction. Every morning, ward-level summaries are generated automatically. Officers no longer begin by asking, "What happened yesterday?" They begin by asking, "Where is pressure building?" Trend lines replace isolated numbers. Movement replaces static reporting. A ward that shifts from low to moderate risk over 3 days becomes visible before it becomes critical. A ward that stabilizes after intervention reflects measurable improvement. Administrative action is no longer assumed, it is quantified. Coordination meetings change in nature. Instead of reviewing scattered reports, departments view a shared risk map of the city. Health, sanitation, and water teams see the same prioritized list. Decisions are aligned in the same room, against the same evidence. This reduces duplication. It reduces delay. It reduces uncertainty in deployment. Importantly, the system also records response time, from signal detection to field verification. Over months, this builds institutional learning. The city does not just respond earlier, it becomes progressively smarter in how it allocates limited capacity. The result is subtle but structural. Not louder alerts. Not heavier reporting. But a municipal system that sees patterns early, acts proportionately, and improves with every cycle. We return to the same neighborhood. The same lanes. The same density. Nothing dramatic has changed. But intervention arrives earlier. Departments act with alignment. Risk is seen sooner. Public health shifts from reaction to readiness. From fragmented signals to integrated intelligence to verified readiness. And the city continues, functioning, monitored, prepared.